My name is Hayit Greenspan. And let me share my screen. Okay, so welcome everyone. And this session is AI and COVID-19. My name is Hayit Greenspan from the Biomedical Engineering Department at Tel-Aviv University. I'm currently on sabbatical at the Icahn School of Medicine, Mount Sinai, New York. I'd like to also mention that I'm a co-founder and chief scientist of Radiomics, Inc. Radiomics is a startup that tries to bring some AI tools to the radiologists. And so I want to welcome you all to our session. It's an honor to organize it and to share it. So we all hoped that COVID would be behind us by now, but what we see is, so this is a dashboard from Johns Hopkins University, and we still see a lot of new cases coming in here in red, and we see many patient cases and death, mortality. So definitely still something we need to consider. And in this session here today, we have a few presentations coming from different directions and different scopes. I will be talking about imaging. We have Dr. Daniel Mean, who will present some work on early detection of COVID-19, Dr. Suvik Virat on theoretical approaches on how we can safely return to normalcy from the COVID-19, Professor Wiro Nissen on the Dutch National Health Data Infrastructure with the COVID as a case study, and Professor Mads Nielsen on population-wide prediction of severity of COVID. As you see, we have an international group, and I welcome you all, and I look forward to our talks and discussions going forward. So let me start with my own presentation. And that has to do with seeing the COVID. Can we see COVID? In fact, in CT and X-ray, we can. And what you see here on the left of this screen are the initial explorations of the radiologists. Dr. Adam Bernheim from Mount Sinai was one of the early radiologists to comment and explain about the disease. And you see here arrows pointing to these opacities, these ground glass opacities, which were found within the lungs as indications of the disease. On the right, you see an AI-based solution that we introduced that deals with 2D and 3D analysis of the data, of the imagery data. And in order to do this scheme, we had to base our models on pre-existing models, which means that we had to use pre-trained models. We had to use very limited amount of annotation. The experts themselves did not yet know how to annotate this data. So this led us to very weak supervision of our models and many more tricks of the AI trade. But definitely we saw that we could very fast achieve the detection of the disease shown here in these red colored maps, localization in 2D and 3D. So this is the first work I just described. We actually named it Rapid AI Development. It came out in March 20, very soon after the first images came out, in basically late January and February. And that is because the company Radiomics had a deployment in China. China is where the images started to come out. And we started working on these limited amount of cases that came out to us. This was a collaboration across several universities and Radiomics. And so the company, so we had here Chinese collaborators. We had Adam Bernheim from New York, Elliot Siegel from University of Maryland, and so on. Since then, we've come up with several additional works, both on CT and X-ray. So I want to show you some of the things that we can extract automatically with AI from the image content. we can quantify these opacities that you see here in red, and basically present a score, which we call the corona score, which is a volumetric measurement of the burden, the percentage of the opacities within the overall lung volume. You see here that we have a case of a patient from late January. So this is one of the first patients, and we're monitoring his condition over time with this corona score. So we actually were able to show that the corona score correlates strongly with the severity of the disease, as the radiologists would label it. We see here a comparison of 14 different patients with the corona score, and we see here a normalized corona score, which basically enables us to show the progression of the disease. In later work, as we improved our segmentation capabilities of the lung and of lobes within the lung, as you see here on top, we extracted additional features, characteristics, or you may call them also radiomics, from the pathology areas. So you see here a long list of features, of geometric features, of relative volumes, and the opacity features, texture of the opacities, and so on. And with all this large set of features that we can extract automatically from the images, in this particular work, we use an ensemble of classifiers, and the output was, if it is COVID or another disease like pneumonia, you see here that we can basically train now at this point on more cases. There's thousands of cases, and they came from China as well as from Russia. So just to note that China and Russia decided to acquire CT imagery of patients. And this is the data set that we have been able to use. And you see very strong performance that is clinically relevant in terms of the area under curve, sensitivity, specificity, for our ability to analyze the image fully automatically. So this was CT. We can do the same thing in X-ray. In fact, other countries, the US, Israel, Western Europe, decided not to acquire CT imagery as the protocol of care. But whenever possible, X-ray was taken. And the question was, can we analyze X-ray then for the COVID? And what we see here is some initial analysis. In red are the opacity areas within these very complex, noisy X-ray images. Again, we can track then the patient over time, and we see very strong results also in this X-ray. In order to build such a system, we need to, again, behind the scenes, segment out the lung very accurately as we can. We need to detect the opacities within the lung, and that means classifying it yes, no, there is opacity, and then localizing it so that we can come up with this nice kind of image characterizing the disease at the end, and also, again, some kind of a score for how much of the lung is occupied with the disease. And if we go even further behind the scenes, the tools that we need to use, as I mentioned in the beginning, are what we can call some of the AI toolkit that we now can use. For example, we can augment data in a variety of ways. So in order to identify segmentation of these very diseased lungs, we had to generate diseased lungs as examples to teach our network to segment out the lung region in order to localize where the pathology is without human experts actually sitting down slice by slice and annotating them. We have a two-phase localization network that learns automatically the location of the pathology itself. Okay, so I wanted to mention very quickly something very, very new in our works. This is work by Dana Cohen in my lab together with Raja Giris from electrical engineering, where we actually use a novel mechanism to generate this kind of data. what you see here on the right is a total synthetic CT image with COVID manifestations in the different slices. This is generated by stylegun network, which is known to be very strong network. And we add an encoder to the discriminator of that network in order to enable us to extract the latent characteristics of each input image that comes into this network. And then what we can do, and once we represent an image in the latent space, in this very disentangled latent space, which is a characteristics of the stylegun, we're able to then play around with the characteristics. So if this is one image, we can add more disease to it as we go here to the right, or actually reduce and basically achieve a healthy characteristic going to the left. So these are some kind of tricks that we can play in this space. So I won't go into more of the details here, but just to say that using this stylegun, self-supervised stylegun, and this latent representation, we're now able to use very small amount of annotated images, small as up to down to 10 annotations, to be able to still characterize if there is pathology or not. This is very new work that is coming out. So in the rest of my talk, I want to transition from the technology to actual clinical practice. Can we use this imaging for COVID-19 in the clinic? You see here on top, Dr. Morozov from Moscow. He has a center of imaging that is responsible for many institutes, radiology institutes, hospital centers, etc. And he basically provides the reading of all of this data. This center is very open to including AI. And what you see down here, already in April 2020, they started using AI-based solutions, something like 5,000 here per day cases that ran through, in this case, it's a radiologic system. They have many systems that they're now experimenting with. And the outputs that they can get for each case that's coming in is an automated report that includes a lot of these quantitations that I described earlier, along with images that basically show very exact high resolution segmentation of the lungs. Also, they can see this in 2D and 3D. They also can get monitoring of the patient. So this is basically summarizing all our capabilities of quantitation and providing them to the radiologists. Is this helpful? Well, the group itself, headed by Morozov, published in ECR 2021 this experiment, including more than 500 radiologists, more than 120,000 chest CTs. The question was, if they used AI or did not use AI, did that affect the accuracy, and did that help in time? And the outcome of this study was that the accuracy stayed as before, but the productivity was raised by 30%. So in fact, we see increase in productivity using the AI tools, which is very promising. What we really want to do is also affect patient treatment or support patient treatment. And I just found a very, very recent new study that shows that basically concludes that the chest CT findings, like the percent of pulmonary involvement, which is basically our corona score, if it's above a certain percent, it is in fact strongly associated with 30-day mortality in COVID-19 patients. Therefore, if these studies come out more and more, we may find ourselves re-examining the idea of using CT examinations. By this study, they are essential for the assessment of severe COVID-19 patients. So to conclude, this experience with COVID really helped us augment AI capabilities. We were actually learning with the radiologists themselves along the way. We saw that it can extract quantitative biomarkers, and we're currently working on combining the image with additional clinical parameters for progressing towards the disease analysis, severity estimation, and to support resource allocation in the healthcare system.